Hello, my name is Dr. Kevin Chamberlain. I'm the University Director of Pharmacy Residency Programs at UConn John Dempsey Hospital at UConn Health. Today we'll discuss new and emerging drug therapy options for the acute treatment and prevention of migraine headaches in adults. For the objectives, we'll discuss current understanding of the pathophysiology of migraines, review diagnostic criteria, talk about the mechanism of action of these newer therapies in migraine treatment options. We'll summarize the role and proper placement of these new therapies, talk about how to transition a patient between migraine therapy, and discuss and outline some key patient counseling points for you to make note of. For disclosure, I have nothing to disclose for financial conflicts of interest pertinent to this talk. There is no cure for migraine. It's a neurological disease that affects 1 in every 4 households in the United States. It's a hereditary condition for more than 90% of those living with the disease and predominantly affects middle-aged adults. The onset is typically late childhood or early adolescence, and peak prevalence occurs in the 5th decade of life. Women, unfortunately, are 2 to 3 times more likely than men to suffer from migraines. And in pre-adolescent children, boys are more likely than girls to suffer from migraines. The cumulative lifetime incidence is reported to be 43% in women and 18% in men, with an incidence peaking later in women, roughly age 20 to 24 years, than in men, where it occurs roughly age 15 to 20. The prevalence is about 15% across US adults and 11% globally, though still higher in women. More than 90% of patients will seek healthcare for recurrent headaches, and healthcare usage amongst migraineurs peaks in the 30s. Let's first discuss pathophysiology of a migraine. Family history is a pertinent risk factor. Risks of about 40% if one of the person's parents has a migraine history, and it increases to 75% if both patients have a migraine history. In patients with migraines, several medications like contraceptives, hormone therapies, or perhaps medication overuse, but also SSRIs and PPIs have data associating risk for medication use with migraines. There's also lifestyle considerations, foods, alcohol, including other factors like lights or environmental issues that could pose or be a potential trigger that increase the risk of having a migraine attack. A migraine is a primary headache disorder in which headaches are typically unilateral and throbbing. They have moderate to severe pain and last anywhere from 4 to 72 hours. Typically, they are accompanied by nausea, vomiting, photophobia, and/or phonophobia. There may also be associated auras. These include visual, sensory, or language disturbances that precede or occur during the headache. The exact mechanism by which migraines occur remains obscure. The pathogenesis of a migraine is most likely due to an imbalance in the modulation of nociception and blood vessel tone by serotonergic and noradrenergic neurons. Plasma CGRP levels increase significantly during migraine attacks and return to normal following relief of the migraine. These calcitonin receptors, or CGRPRs, and amylin-1 receptors are the only calcitonin receptors to so far be implicated in migraine pathophysiology. This CGRP receptor regulates key events that underlie migraine pathophysiology, including trigeminal neuron sensitization and neuropeptide release. The amylin-1 receptor is expressed in the vasculature and the trigeminal ganglion, and also the pancreas, but it's unrelated to migraines here. The amylin-1 receptor is a continuing area of study and interest for its role in migraines. Diagnosis of a migraine requires headaches to occur 15 days per month, and only 8 of which have to exhibit migraine-associated features. This is newer criterion that has come into use. Migraines can be divided into phases on the basis of its temporal relationship to headache. Phases 1, 2, 3, and 4 include the premonitory phase, which precedes the headache, the aura phase, which is immediately before or accompanying the headache phase, and the postdrome phase, or the resolution of the headache. Although this description of a migraine is practical, in reality, the phases can commonly be overlapping and variable. Phase 1, the prodrome. Activation of the hypothalamus, as well as neuropeptides such as leptin, neuropeptide Y, and orexin A and B, are involved in homeostatic functions, and they may contribute to symptoms experienced during the prodrome phase. Studies show that activation of the hypothalamus occurs prior to the start of the migraine pain. A variety of symptoms, including yawning, polyuria, mood change, irritability, light sensitivity, neck pain, and difficulty concentrating, amongst others, commonly occur hours before onset of headache during a migraine attack. Although some of these symptoms are subjective, others, particularly sensory sensitivity, can be objectively quantified. For example, changes in quantitative sensory thresholds occur hours before headache, consistent with the occurrence of subjective sensory symptoms in the premonitory phase. Imaging during this phase shows changes in the activity and connectivity of the hypothalamus in the hours preceding headache. The activation of the brainstem is correlated with nausea. Phase 2 is the aura. A long-standing hypothesis is that the aura is a primary initiator of a migraine attack, leading to headache and other migraine symptoms. Cortical spreading depression is considered to be the primary pathophysiology behind an aura phase. In essence, it is hypothesized that the trigeminal-vascular system is activated and it depolarizes the gray matter, inhibiting cortical activity and resulting in changes in blood flow and metabolism, and thus drives the aura symptoms patients experience. Population studies indicate that a diagnosis of migraine with aura is associated with an increased risk of other comorbidities, such as patent foramen ovale, ischemic stroke, including perioperative stroke, restless leg syndrome, Parkinson's disease, bipolar disorder, and panic disorder. Migraine aura commonly occurs without headache, and most migraine attacks do not include an aura, indicating that the aura is not necessary or sufficient for headache. The occurrence of an aura during a migraine is variable for most patients. Although visual symptoms are prevalent, sensory, language, and olfactory symptoms are also common and might occur either in conjunction with or independently of visual symptoms. The classic scintillating scotoma of migraine, as seen on your screen, occurs in approximately 50% of patients reporting visual aura. Phase 3 is the crux of the migraine, the headache. Sensitization of the central and peripheral trigeminal vascular system can create a state of hypersensitivity and sustained pain. The pain is experienced when the trigeminal vascular neurons are activated and relay the migraine signal from the periphery to the CNS. Repeated activation of the trigeminal vascular system over time results in a state of nervous system hypersensitivity and sustained pain. Feedback from the sensitized brain will both 1. Potentiate pain signaling, and 2. Contribute to common migraine symptoms such as photophobia, phonophobia, and pain sensitivity. The last phase is the postdrome. There are a number of similarities in the symptoms experienced during the prodrome and the postdrome phases. However, the precise pathophysiological events that underline these symptoms remain unclear. Neuropeptides may contribute to the pain and sensitization of pathways in migraine processes. CGRPs, or calcitonin gene-related peptides, and PACAPs, or pituitary adenylate cyclase activating polypeptide, are both neuropeptides that have been identified and at increased levels during migraine attacks. Thus, newer therapies target these peptides and/or their receptors. Functional imaging studies have demonstrated that changes in the activity of multiple brain regions may persist for hours following headache relief, which may give rise to some interictal symptoms, including olfactory, light sensitivity, and fatigue. So let's pause and ponder. Can a migraine exist without an aura? Moving on to diagnostic criteria. Again, migraines can occur without an aura, and typically this would be a headache that lasts 4 to 72 hours with two of the following items listed on your screen: aggravation by or avoidance of routine physical activity, moderate or severe pain, pulsating quality, unilateral locale, and during the headache, one or more of either nausea and vomiting or photo or phonophobia, with a history of 5 or more attacks fulfilling the above criterion. Compared to a migraine with an aura, the aura with one or more of the following without a motor weakness, or two of the following listed in mid-screen on the right-hand side: homogeneous visual or unilateral sensory symptoms, one or more aura symptoms gradually over 5 minutes, or different symptoms in succession over 5 minutes, each symptom lasting at least 5 minutes but not longer than an hour. And the headache fulfilling criteria for a migraine without an aura begins during or follows within 60 minutes of this. Here, you only need a history of 2 or more attacks fulfilling the above criterion to meet diagnosis. But there are easier ways. Can the clinical assessment distinguish patients with migraine from those with other types of headaches? A high-quality student evaluated the screening tool comprised of 5 criteria, known as the POUND criteria listed on the left side of your screen. These clinical features include the pulsatile quality of headache, a 1-day duration of headache lasting 4 to 72 hours if untreated or unsuccessfully treated, a unilateral headache, nausea or vomiting, and disabling intensity of headache. The presence of 4 or more features provided a high likelihood ratio of diagnosing a definite or possible migraine. Including typical aura symptomatology, however, did not improve diagnostic accuracy, further strengthening the mnemonic's utility in practice. But of course, there's a differential diagnosis. There are other serious causes of headache that must be considered: acute glaucoma, carbon monoxide poisoning, encephalitis or meningitis, and various vascular disorders including acute severe hypertension, cerebrovenous thrombosis, or cervical artery dissection need to be ruled out. To further assist with diagnosing, the SNOOP 10 criteria may be helpful in identifying red flags suggesting a secondary cause of headache. The SNOOP 10 criteria with related secondary headache diagnosis includes the items listed on your screen: systemic symptoms, neoplasm. Consider whether or not if there's a neoplasm or if it's a metastases. Neurologic symptoms or abdominal signs such as confusion, impaired alertness or consciousness, and a focal exam. And here you would consider headaches attributable to vascular or non-vascular intracranial disorders, a brain abscess, or perhaps another infection. The onset, whether or not it's sudden, abrupt, or split second. Sudden would be the worst. Consider subarachnoid hemorrhages here. Older age at onset, specifically above 50 years. Consider giant cell arteritis and other headaches attributable to cranial or cervical vascular disorders or non-vascular intracranial disorders. Whether there's a pattern change or recent onset of headache, here you would consider again neoplasms or headaches attributable to vascular or non-vascular intracranial disorders. A positional headache, precipitated something by sneezing, coughing, or exercise. Here you might consider posterior fossa malformations or Chiari malformation. Whether or not there's papilledema, so consider neoplasms again and other non-vascular intracranial disorders. Progressive headache and atypical presentations, you might again consider neoplasms. Pregnancy, here you might consider a headache attributable to cranial or cervical vascular disorders, a post-duropuncture headache, or a hypertension-related disorder such as preeclampsia. And lastly, painful eye with autonomic features. Here you might consider pathology in the posterior fossa, the pituitary region, or the cavernous sinus, or other ophthalmic causes. So let's move into describing the mechanism of action of these new preventative and acute migraine therapies. The approach to migraine therapy remains as you see it on your screen, with the acute being led with NSAIDs, acetaminophen, perhaps metoclopramide or prochlorperazine as antiemetics, and of course the triptans and steroids. There's also the ergotamine derivatives, haloperidol and valproate, and also some CGRPs fit in here in the acute management. Prevention is still led by beta blocker therapy, with those items listed as the top two with propranolol and timolol, but you might also consider some antiepileptics like topiramate or divalproex, some antidepressants like TCA specifically, but also aspirin and other agents listed again, and of course CGRPs fit here as well. We've talked about these CGRPs a couple of times. So what are they? The calcitonin gene-related peptides, these CGRPs or gepants, are mediators of migraine and thus an important target for therapeutics. Studies show that the CGRP is released into circulation during a migraine or cluster headache attack, and that it normalizes with triptan therapy, but not with nonspecific opioid analgesics. CGRP concentrations, again, CGRP is an inflammatory compound, remain persistently elevated in patients with chronic migraine. Several small molecule CGRP antagonists have shown efficacy as acute migraine therapies. Pharmacologic modulation of CGRP activity appears to mediate the trigeminal-vascular pain transmission that occurs in migraines. Monoclonal antibodies directed against the CGRP receptor or ligand are given by injection for migraine prevention. These small molecule CGRP antagonists, also known as gepants, are oral options available for the acute treatment of migraine in patients with either insufficient response or contraindication to standard therapy or treatment with triptans. The first we'll talk about is ubrogepant. It's FDA approved for acute treatment of migraines in adults with or without aura. Almost 2,700 patients participated in the ubrogepant ACHIEVE studies. The doses have ranged from 25 to 100 milligrams. The Tmax is roughly 0.7 to 1.5 hours after first dose. Approximately 20% of patients who used the 50 milligram dose were pain-free after 2 hours. Ubrogepant as a whole was well tolerated, with only 2 to 5% of patients reporting nausea, somnolence, dry mouth, dizziness, or upper respiratory tract infections, and no serious adverse events were reported. The safety and tolerability were also explored in a 52-week extension study of ACHIEVE. Few adverse events and no hepatotoxicity was reported. The effect of ubrogepant on the patient's most bothersome migraine symptom was evaluated 2 hours post-dose, and 39% of those treated with ubrogepant reported that their worst migraine symptom was resolved. The therapeutic gain for ubrogepant, active drug versus placebo, is relatively low, ranging 6.4% to 9.4%. Comparatively, the therapeutic gain for sumatriptan is between 16 and 21%. From the ACHIEVE studies, we understood the dosing of 50 or 100 milligrams orally as needed. If needed, a second dose can be administered at least 2 hours after that first dose, but the max dose in 24 hours is 200 milligrams. In patients with severe hepatic or renal issues, 50 milligrams for the initial and the repeat dose is the max. The drug should be avoided in those patients with end-stage renal disease, and while we don't know for sure, we typically want to avoid these drugs in pregnancy because they may cause fetal harm. Nausea and somnolence occurred greater than 2% versus placebo in the studies. Of note, there are drug-drug interactions of concern. CYP3A4 inhibitors should be avoided. If moderate CYP3A4 inhibitors are concomitantly used, you need to avoid that second dose for at least 48 hours. Strong 3A4 inducers should also be avoided. Potent inhibitors of CYP3A4 include clarithromycin or erythromycin, diltiazem, itraconazole, ketoconazole, verapamil, and grapefruit. Inducers of 3A4 include phenobarbital, phenytoin, rifampicin, and St. John's wort, as well as glucocorticoids. P-glycoprotein inhibitors are also of something to be concerned with, and this could result in a significant decrease, or rather a significant increase in ubrogepant exposure and should be avoided. P-glycoprotein inhibitors include amiodarone, azithromycin, carvedilol, tacrolimus, and verapamil. For what it's worth, inducers would include carbamazepine, phenytoin, phenobarbital, and St. John's wort. The pharmacokinetic parameters for the drug are listed to the right side of your screen, with max concentration being reached in roughly 1.5 hours. While food delays the peak by about 2 hours and causes some reductions in Cmax, there was no effect on the AUC, and so we administer without regard to food. It is a reasonably highly protein-bound drug, again a 3A4 substrate with 2 non-clinically important metabolites, and its elimination is primarily biliary and fecal, with renal being a minor route of elimination. Its elimination half-life is at about 5 to 7 hours. Rimegepant is another gepant. It's in development for abortive and preventive use, but currently only approved for migraine abortive therapy. The dose is 75 milligrams with a Tmax of about 2 hours. In the 2 main trials, almost 20% of patients achieved pain freedom at 2 hours. 37% of patients reported freedom from their most bothersome symptom, and no significant liver toxicity was reported. Adverse events were relatively low, with nausea being reported in about 1.5% of patients. The therapeutic gain for rimegepant is 5% to 7.5%. Its efficacy is based on a clinical study of almost 1,500 patients randomized to rimegepant versus placebo, where patients were allowed to also use rescue medications such as NSAIDs, acetaminophen, and/or antiemetics 2 hours after the initial treatment, but other forms of rescue medication, for example triptans, were not allowed within 48 hours of initial treatment. When you compare rimegepant versus placebo, patients were pain-free, defined as a reduction of moderate or severe headache pain or to no pain, at 2 hours in 21% of treated patients versus 11% of placebo patients. Patients also self-identified freedom from the most bothersome symptom, including phonophobia, or nausea, 2 hours after their dose in almost 35% of patients treated versus 27% placebo. The dosing is listed here, with 75 milligrams orally as needed being the dose, and it's also the max per 24 hours. The safety of treating more than 15 migraines per 30 days has not been established, and it's not yet approved for preventative treatment. It was not studied specifically in end-stage renal disease patients and should be used in caution with hepatotoxic patients meeting Child-Pugh Class C criterion. Only nausea is reported to occur in more than 1% of patients that were treated with rimegepant. It again has drug-drug interactions of concern relevant to 3A4 and P-glycoprotein, as mentioned earlier. Its kinetics are listed on the right hand of the screen. Its max concentration is reached in 1.5 hours, and its absolute bioavailability is 64%. Food does delay its peak by 1 hour, but the effect on efficacy is unknown. It is a highly protein-bound drug. Again, it's a 3A4 substrate for metabolism, less so by 2C9, and may not be clinically relevant at this point with the data we know. And it's eliminated primarily unchanged with an elimination half-life of 11 hours. So for the CGRPs, in whom do we use them? The gepants may be helpful for 3 groups of migraineurs. They will be prescribed for a number of patients who found triptans to be ineffective. Additionally, gepants will be used for certain patients who cannot tolerate those triptans. And finally, for those patients with significant cardiac or cerebrovascular risk factors, the gepants may be a relatively safe option since they do not constrict cardiac or cranial arteries. A different class of medication, lasmiditan or Rayvow, was FDA approved for the acute treatment of migraine in adults with or without aura. It's a selective serotonin 1F receptor agonist that lacks vasoconstrictor activity. The role of lasmiditan in clinical practice is not really yet identified or defined, but it's probably best suited for patients with relative contraindications to triptans due to cardiovascular risk factors. In a randomized trial of more than 2,200 patients with episodic migraine, the proportion who were headache pain-free at 2 hours was greater with lasmiditan 200 milligrams, 32% versus 15% with placebo, and lasmiditan 100 milligrams, 28% versus 15% placebo. Lasmiditan was also effective for treating acute migraine in another randomized placebo-controlled trial of 2,300 patients. In October of 2019, the FDA approved lasmiditan oral tablets for the acute treatment of migraine in adults, with that initial dose of 50 milligrams taken once. There has not been identified a benefit with taking a second dose for the same migraine attack. However, with subsequent attacks, the dose may be increased to 100 or 200 milligrams as needed, but no more than one dose should be taken in 24 hours. So again, the dosing is either 50, 100, or 200 milligrams orally as needed as defined previously, and the max per 24 hours is that one dose of whatever the patient first starts with. There's no dose adjustment needed in severe renal impairment, and it hasn't been studied in severe hepatic impairment. Lasmiditan has a relatively high rate of adverse events, and the most common being dizziness. Other relatively frequent adverse events are paresthesias, somnolence, fatigue, and nausea. Dizziness with lasmiditan is a dose-dependent and largely mild to moderate in severity adverse effect, with a median duration of 1.5 to 2 hours. The drug may cause driving impairment, and patients should not drive a motor vehicle, operate machinery, or engage in potentially hazardous activities for at least 8 hours after each dose of lasmiditan. It's noted that PGP inhibitors should be avoided because they can result in significant increase in lasmiditan exposure. Again, P-glycoprotein inhibitors include amiodarone, azithromycin, carvedilol, tacrolimus, verapamil. The kinetic parameters are listed on the right side of your screen, with the max concentration reached in just under 2 hours. Food does increase the area under the curve by as much as 20% and can delay Tmax by an hour. It's moderately protein bound, and it has no CYP450 hepatic metabolism to inactive agents. Primarily, the SM8 metabolite is eliminated and takes about 5.5 hours for its elimination half-life to be achieved. Shifting to migraine prevention. When would we consider using prophylactic medications? We would if the patient requests it, if they use acute treatments 2 or more days per week or more than 3 times per month, if the migraines decrease their quality of life, and if the acute treatments are ineffective or contraindicated. A patient may have to try multiple agents before finding the one that works well for them. That trial should be at least 2 to 6 months per agent. Prevention can be done with drugs like Botox, and no, I'm not going to try to say that generic name. Botox is FDA approved for prophylaxis of headaches in adults with chronic migraine. It is not, however, approved for episodic migraine. And while it was statistically superior to placebo in randomized trials, the magnitude of the difference is relatively small. The American Academy of Neurology has level A evidence that says it can be offered as a treatment to increase the number of headache-free days, and level B evidence where it can be considered to reduce headache impact on the health-related quality of life. Where do the CGRPs fit in prevention? 4 agents are listed on your screen. And in 2018, the FDA approved the first CGRP inhibitor, irenumab, but also fremanezumab and galcanezumab for the preventive treatment of migraines in adults. The American Headache Society released a position statement on integrating these new migraine treatments into clinical practice. Unlike oral prophylaxis agents, the CGRP inhibitors do not require a slow dose escalation. They have a faster onset of therapeutic benefit, and they have favorable tolerability profiles. The American Headache Society recommends initiating these CGRP inhibitors for migraine prophylaxis in patients over the age of 18 that meet the following: a diagnosis of migraine with or without aura, experiencing 4 to 7 monthly headache days with moderate disability and inability to tolerate or inadequate response to a 6-week trial of at least 2 oral prophylactic agents. Or patients that have a diagnosis of migraine with or without aura, experiencing 8 to 14 monthly headache days and an inability to tolerate or inadequate response to a 6-week trial of at least 2 oral prophylactic agents, or diagnosis of chronic migraine and either the inability to tolerate or inadequate response to a 6-week trial of at least 2 oral prophylactic agents or at least 6 months of Botox treatment. According to the American Headache Society, response to CGRP inhibitor therapy should be assessed after 3 months for monthly injections or 6 months for quarterly injections. Therapy should only be continued if clinically meaningful treatment benefit can be documented. The statement also addresses non-pharmacologic therapy, including neuromodulation and biobehavioral therapies. Irenyumab or Aimovig is the first one that we'll discuss. The dosing is listed here as 70 milligrams subcutaneously once monthly via an autoinjector, but some may require a dose up to 140 milligrams. Development of hypertension and worsening of pre-existing hypertension have been reported following the use of Irenyumab in the post-marketing setting, and many of the patients had pre-existing hypertension or risk factors for hypertension. There were cases requiring pharmacological treatment and, in some cases, hospitalization because of the hypertension. The hypertension may occur at any time during treatment, but was most frequently reported within 7 days of dose administration. And in the majority of cases, the onset or worsening of hypertension was reported after the first dose. In these patients, the drug Irenyumab was discontinued. So we should monitor patients treated with Irenyumab for new onset hypertension or worsening of pre-existing hypertension, and consider whether discontinuation of Irenyumab is warranted if evaluation fails to establish an alternative etiology. Irenyumab is a human monoclonal antibody that binds to and inhibits the CGRP receptor and was modestly effective for migraine prevention in a placebo-controlled trial of over 900 adults with episodic migraine, as seen on the right side of your screen. The trial randomly assigned subjects in a 1:1:1 ratio of subcutaneous injections of either Irenyumab 70 milligrams, Irenyumab 140 milligrams, or placebo monthly for 6 months. At baseline, the mean number of migraine days per month was 8.3 in the overall population. At months 4 through 6, the number of migraine days per month was reduced by 3.2 in the 70 milligram group, 3.7 in the 140 milligram group, and only 1.8 in the placebo group. The rates of adverse events were similar between the Irenyumab and placebo groups. 3 other studies, for approval include the STRIVE, ARISE, and LIBERTY. Fremanezumab, or Ejavoy, is dosed at 225 milligrams subcutaneously once monthly via autoinjector or syringe, or as 675 milligrams given as subcutaneous injections every 3 months, as number 3 consecutive 225 milligram injections. That is a typo on your screen with the some may require 140 milligrams. I apologize. The adverse effects seen with this particular medication were only known to be injection site reactions to occur greater than placebo. The studies that were used to approve Fremanezumab include the HALO-EM, which tested the medication in episodic migraines, and the HALO-CM, which looked at chronic migraines. Galcanezumab, or Emgality, is dosed at 240 milligrams as number 2 120 milligram injections subcutaneously via a pre-filled pen or syringe once, and then 120 milligrams subcutaneously once monthly thereafter. Again, only injection site reactions were identified in the studies for approval of Galcanezumab, which include EVOLVE-1, EVOLVE-2, and REGAIN. Galcanezumab is a human monoclonal antibody that binds to the CGRP ligand and again is modestly effective for episodic migraine prevention, as demonstrated in several placebo-controlled trials. One of these trials randomly assigned 858 patients with episodic migraine to monthly subcutaneous Galcanezumab 120 milligrams, Galcanezumab 240 milligrams, or placebo in a 1:1:2 ratio. At 6 months, the mean number of migraine days per month decreased by 4.7 and 4.6 for the two treatment groups of 120 and 240 milligrams, respectively, compared with only 2.8 days for the placebo group. The fourth CGRP for prevention is eptinizumab, or Vyepti. This is a medication that's actually administered IV in 100 milliliters of 0.9% normal saline injection every 3 months over a 30-minute infusion. It's initiated at 100 milligrams, but some may benefit from a dose as high as 300. It's a monoclonal antibody that binds to both isoforms of the CGRP ligand. Its adverse events, most notably, were nasopharyngitis, fatigue, and again, hypersensitivity reactions. Data from 2 randomized controlled trials support modest efficacy for the prevention of episodic migraine. The PROMISE-1 trial randomly assigned 888 patients in a 1:1:1:1 ratio to IV eptinizumab 30, 100, or 300 milligrams versus placebo, administered every 12 weeks for up to 4 IV doses. The reduction in a mean monthly migraine days from baseline was approximately 4 for each of the eptinizumab dose groups, compared with approximately 3 days for the placebo group. In addition, a greater than 50% reduction in migraine days was achieved by more patients in the 100 and 300 milligram eptinizumab groups, 50 and 56%, versus only 38% in the placebo group. On the lower portion of your screen is the data from the PROMISE-2 trial, a trial of more than 1,000 adult patients with a history of chronic migraine, defined as 15 to 26 headache days per month, and more than 8 of which were migraine days. Mean monthly migraine days were reduced by approximately 8 days in the 100 milligram group and 300 milligram groups, compared with approximately 6 days for placebo group. As a class, adverse effects are consistent across all injection site reactions: pain, erythema, pruritus, with erenumab at 5 to 6% versus 3% placebo, fremanezumab roughly 43 to 45%, and galcanezumab 18%. Antibody data, upwards of 6 or more % in some users were seen. They were detected specifically for erenumab, fremanezumab, and galcanezumab, but data is limited on its impact to this point. There is also limited safety and efficacy data in pediatric and geriatric patients and are thus not recommended for use. Additionally, there is inadequate data to inform of developmental risks, and thus CGRPs are not recommended for use in pregnancy at this point. Let's pause and ponder again. Which of the following CGRPs cause potentially problematic cardiovascular side effects, and what are those effects? As we talk about the role of new therapies, we'll summarize the role and proper placement of these new migraine therapies among existing options. Migraine is a complex neurological condition that can involve debilitating headache and sensory changes. Migraine attacks are usually episodic, but some migraine sufferers experience chronic daily headaches at least 15 days per month, often with migrainous features. Triptans have become the drugs of choice for treating acute migraine attacks with a response rate of about 60%. Studies suggest that 38 to 50% of migraineurs are candidates for preventative therapy, and indications for preventative therapy include 4 or more migraine attacks per month, or 8 or more migraine days per month, acute medication overuse, and debilitating migraine. General first-line recommendations for either episodic or chronic migraine prophylaxis include oral medications such as beta blockers, antiepileptics, and antidepressants. However, side effects and failure to completely eliminate the headache pain result in low adherence to preventative therapy, estimated at only 20% after 1 year of treatment. The American Headache Society says to incorporate CGRP inhibitors in preventive migraine therapy in the patients that meet the following: those experiencing episodic or chronic migraine who cannot tolerate or who have had an inadequate response to a 6-week trial of at least 2 prophylactic agents, or those that cannot tolerate or inadequate or have had an inadequate response to a 6-week trial of Botox in patients with chronic migraine. The American Headache Society says that rimegepant, which is the only oral ODT CGRP inhibitor, so orally disintegrating tablet, it's also the only one approved for acute treatment of migraine, and it's recommended for patients who have failed at least 2 oral triptan agents or who are not candidates for triptan use. Although probably unrelated to treatment, there have been 3 deaths in clinical trials who received CGRP monoclonal antibodies. Additional concerns have been raised about the potential for adverse cardiovascular, pulmonary, and psychiatric effects with CGRP antagonists, even though these were not directly observed in randomized trials. CGRP has theoretical cardioprotective and vasodilatory effects, so CGRP antagonists may affect this. There is little evidence to guide the use of CGRP antagonists in specific populations like children, older adults, and women during pregnancy and lactation. Some experts recommend avoiding the use of CGRP antagonists for women who are pregnant or likely to become pregnant, given the potential risks of reducing the action of CGRP during pregnancy. More data is really needed regarding the long-term safety of this class of medications. The FDA recently expanded the approval for Nerivio, a wearable remote electrical neuromodulation device controlled by a smartphone app, to treat the chronic migraine in adults aged 18 years and older. It was previously FDA approved for the treatment of episodic migraine. This wearable device uses remote electrical neuromodulation to activate the conditioned pain modulation of the brain to treat pain and other migraine symptoms. 2 studies presented earlier this year at Pain Week showed that after using Nerivio, more than 56% of participants achieved pain relief at 2 hours, and 22% achieved pain freedom. Among these participants, more than 75% had sustained pain relief at 24 hours. The new indication offers a non-pharmaceutical intervention option for patients with chronic migraine with similar efficacy to migraine medication while avoiding medication overuse. There's more to come on this advanced technology for migraine sufferers. Now we're going to discuss how to safely transition a patient between migraine therapy options. Thus, it is crucial that patients understand that any of the following can define success in migraine prevention: 50% reduction in frequency of days, significant decreases in attack duration or severity, improved treatment response to acute treatment, reduction in migraine-related disability, and improvements in function in important areas of life, and improvements in the health-related quality of life and reduction in psychological distress due to the migraines. In some patients, a less than 50% reduction in monthly headache days produces benefit, while in others, especially those with daily or continuous headache, a significant reduction in the overall severity of headache may lead to improvements in function and health-related quality of life. The success of preventive therapy depends on establishing realistic patient expectations for the given treatments. What are some key counseling points? Next, we'll outline some key counseling points for medications such as dosing, administration, and adverse drug effects and monitoring. Firstly, in our roles, what to ask. Should we bother doing a detailed patient interview? Yes, and the goal is to identify the specific kind of headache by doing such. Where is it located? Is it unilateral, mostly seen in migraines, or bilateral? When and how did the headache start? Is there a specific event or trigger? How often do they occur? How long do they last? What treatments have you tried, and were they effective or ineffective? Are there other symptoms besides the headache? Is there a family history? And what effect does the headache have on the quality of life for the patient? We'd be remiss if we didn't discuss non-pharmacological treatments. So we want to counsel patients to avoid common triggers such as the ones listed to the right side of your screen: stress and anxiety, an inconsistent diet, sensory stimuli like lights, loudness, and smells, lack of sleep, changes in weather, and medications as alluded to earlier, such as contraceptives and vasodilators. We'll briefly touch on triptans, though the focus of this talk is not on them. Common adverse events for triptans include somnolence, paresthesias, hot or cold sensations, and this thing identified as a triptan sensation, which is pressure in the chest or neck that dissipates over time. Adverse effects with triptans typically occur right after the drug is taken and also go away quickly. But they're contraindicated in certain patients, those with a history of stroke or TIA, those with uncontrolled hypertension, and those with ischemic heart disease or signs of ischemic heart disease like angina, MI, or coronary artery disease. Triptans have a number of drug interactions, and the FDA warns against combining triptans with other serotonergic drugs for the increased risk of serotonin syndrome. And while it's not a contraindication, we do want to advise patients to look for the signs of potential serotonin syndrome, so to identify things like restlessness, agitation or delirium, tremors, or sweating. Sumatriptan, rizatriptan, and zolmitriptan use is contraindicated within 2 weeks of an MAOI. Triptans cannot be given within 24 hours of an ergotamine. You want to avoid elatriptan with strong 3A4 inhibitors, and you want to avoid rizatriptan with propranolol, which can be problematic in those needing a preventative treatment. Other beta blockers like atenolol, metoprolol, nadolol, and timolol do not do this. Further, not all triptans are created equal. Dosage forms can vary among various products. They are all available in tablet form, but only some are available as nasal sprays or ODTs, or even a subcutaneous injection. Provatriptan and naratriptan are classified as longer acting, but because they have a longer half-life, they also have a slower onset of action, at least for these two. They might be better for recurring headaches or headaches that last a long time. All the other ones are considered fast-acting. They have a shorter half-life, but a faster onset of action, so choose wisely. A few are sulfa-containing moieties, like provatriptan, rizatriptan, and zolmitriptan. Or rather, those three do not have a sulfa moiety, sorry. All the others do. And concurrent CGRP use is not well studied with triptans, and so we need to proceed with caution. For the CGRPs, rimegepant, it's an ODT tablet, so you want to remind the patient to dry their hands when handling it, to gently remove it from the foil pack and not to push it through, to place on or under the tongue because it will disintegrate in the saliva, and to take immediately after opening the foil blister pack. For the preventative CGRP mAbs, they're auto-injectors, so we want to follow the standards of administration specifically for arenumab and fremanezumab. The auto-injector and prefilled syringes are one-time use only, so they'll need to have a proper disposal. Further, arenumab is a syringe, and both the syringe and the injector contain a derivative of latex, so it may be of caution for those patients with a latex hypersensitivity. We store these in the fridge, and we want to warm them to room temperature for at least 30 minutes, but we don't want to shake them. Arenumab and galcanezumab can be stored in the fridge and used within 7 days after coming to room temperature. But fremanezumab should only be used within 24 hours of removal from the fridge. Further, the company websites often have patient support services available, including text message-based tracking for migraine symptom days and videos for how to use the injection devices that patients may find helpful. Lasmiditan should not be administered unless the patient can wait 8 or more hours between dosing and operating machinery or driving. And it's not for use with rimegepant because it's a 3A4 inhibitor and will increase effect and toxicity. CNS depression is that side effect of concern with lasmiditan and really will probably limit its use. Let's pause and ponder one last time. What are some realistic expectations for migraine sufferers being considered for preventive therapy? Let's wrap up with some key takeaways. CGRPs are a new option to the migraine armamentarium, but their side effect profile is still being sorted out. They offer a triptan sparing and other therapeutic alternative, but have side effects that warrant monitoring and consideration in some patients. Opioids generally are not as effective as migraine-specific medications for acute migraine treatment. Additionally, the use of opioids is complicated by their potential for tolerance, dependence, addiction, and overdose. And the use of opioids and barbiturates like butalbital is associated with an increased risk for the development of chronic migraine and medication overuse headache. Preventative migraine therapy requires a sustained commitment on the part of the patient and physician to achieve benefit. The pain medications for migraine prevention therapy are frequent or long-lasting migraine headaches and migraine headaches that cause significant disability or diminished quality of life. In addition, preventive migraine therapy is indicated to reduce the risk of neurologic damage and/or impairment in the presence of uncommon migraine conditions, including hemiplegic migraine, migraine with brainstem aura, and migraine with prolonged aura. Alternatives include the calcium channel blockers like verapamil, which may be less effective but are generally safe and well tolerated, and the CGRP antagonists, irenicimab, fremanezumab, galcanezumab, and eptinezumab, which were effective in randomized trials, but are expensive and lack long-term safety data. Thank you.
Thank you, Dr. Chamberlain, for that. That was a lot of MABs.
Yeah, I would have to say that saying the names is as challenging as the disease state itself.
Absolutely. You saw we have a couple of questions already in the queue there. Do you want to go ahead and address those that have been popping up?
Yeah, sure. So the last question I saw from attendee Jeff, why in practice do we see triptans used in conjunction with Nurtec or other CGRPs if they're recommended after patients failed triptans? So, you know, I'm going to take the easy answer on this one, unfortunately, and it's really that the combination of therapies, it's still being studied. As I understand it, none of the current labeling actually supports or fairly either supports or refutes the co-administration of the products together. So CGRPs with triptans. It's really thought that when you get to the CGRP need, right, because it's on, it's essentially second or third line therapy right now in the current guidelines for migraine treatment or prophylaxis, that it's really because those patients haven't responded adequately or well enough or have some level of intolerance to standard of therapy, which is right now currently the triptans still. There was a question earlier. I got to go back and scroll up and find it though. Where was it? No, maybe not. Maybe I was just responding to the pause and ponders, I guess.
Well, speaking of pause and ponders, there was one that I would like to go back to for a moment. Number two, which of the CGRPs cause potentially problematic cardiovascular side effects, and what are those effects? Can you kind of go through that a little bit more? I think from the answers that maybe that was could use a little delineation.
Yeah, so I saw in a lot of the responses on the poll that a lot of people were kind of referring to the cardiovascular issues that are associated with triptans, right? So they're actually proceed with caution, if you will, for use in patients that have coronary disease. So triptans are really, that's one of their rate limiting effects, right? So some of them are sulfa products, so that can be an issue in some patients, although they contain sulfa moieties. It's not a true sulfur allergy like you might see with an antibiotic like Bactrim or what have you. So that's one component. The cardiovascular stuff though is problematic long-term in patients with long-standing cardiac disease. And it's just a concern to be monitoring for. The only gepant or CGRP that we've seen any cardiovascular associated risk with so far is irenicimab with its hypertension component. So if patients have well-controlled hypertension, you could consider still using it. You would just monitor them very closely. You'd probably bring them in more frequently for follow-ups to make sure that, you know, during the first 3, 6, and 12-month period of exposure to the irenicimab, that they were doing well and that their blood pressure was holding steady. And any kind of, you know, sway from good solid blood pressure control, you would probably have to move on from that therapy. But so far, that's the only new drug, if you will, CGRP, that's had any sort of cardiovascular issue.
So, speaking of MABs, obviously a lot of monoclonal antibodies are effective here. Are there technologies coming down the pike that maybe aren't MABs or iterations thereof that are of interest?
Yeah, I mean, right now, the primary focus that I've seen in any of the pipeline stuff is focused on this CGRP derivative, and most of those are going to be MAB based. We talked a little bit about that drug lasmiditan that has some serotonergic effects, but it kind of has, a rate limiting significance of that CNS depression component and its ability to be co-administered with other drugs that require that cytochrome P453A4 isoenzyme. And so because that's such a proliferative metabolism pathway, that's going to be a rate limiting step for that drug. So right now, the targets are really on this CGRP. It's been there over the last 5 to 10 years. I actually gave a talk for CPA a few years back, and we were looking at down the pipeline then, and we were just kind of introducing CGRPs. So it's interesting now, 2 to 4 years later, kind of how they've moved up and they're present, right? We have about 5 or 6 of these now. But really, they haven't moved up on kind of the ladder of step approach, right? We're still looking at triptans and NSAIDs and acetaminophen as kind of entry level management to mitigate migraine disease and symptomatology.
Interesting. Do we have any other questions from the audience right now? If not, Dr. Chamberlain, I'm going to thank you very much for your presentation today. That was fascinating. Again, tons of useful information for our audience. The program code for our audience is the word criteria, CRITERIA, criteria.